So, welcoming everyone. Welcome, welcome. And delighted to have you to join us with PHN and Royal Melbourne Hospital staff on the National Lung Cancer Screening Program. So, it's all new and we're building on our knowledge as we go. And today we're looking at essentials in pulmonary nodule management and risk factors. Thank you, Asha. So I'd like to acknowledge that we're meeting today on the lands of the Wurundjeri, Wurrung people, the Bunurong people and the Wathaurong people, and like to pay my respects to elders past, present and emerging, and to any Aboriginal and Torres Strait Islander people in attending with us today. And the land was never ceded, so thank you for joining us. And next slide. So just some housekeeping. We encourage you all to stay muted and just be aware if you are on an iPhone or a phone that you might unwittingly unmute. So just try to keep an eye on keeping muted, particularly if you've got background noise. And you have the opportunity to ask questions in the chat box. We are recording the session, so if you do miss part of it or want to go back, we will be putting it on the PHN platform, so you can go back and listen to it, or other people can. Now, for your CPD points, it is important that you put your correct name in the, you rename yourself. So just be aware, like somebody's iPhone, if that comes up, we don't quite know exactly who it is, so we can give you the right points for your CPD. So just make sure you rename yourself, and that can be done by going into the top right hand corner and going the ... and renaming yourself in your Zoom window. Next slide, thank you. And questions will all be in chat. I'll be monitoring the chat. Oh, so here is how you can just change your name if you need to. So click on participants or click on your Zoom window, hover over it to that 3 dots, rename, and put a name that we will actually know is you, so we can give you CPD points. Next slide, please. And so just to give you an idea how the time is going to be spread out over the session today. So we're going to be doing some polls. We'll be doing looking at the fundamentals of the nodules and risk assessment, and going further into the non-screen detected nodules and what you do when you have your screen detected pulmonary nodules, which as a GP can often be a bit of a nightmare. We're going to be doing some case studies to actually illustrate what you do need to do. Some cases will be worked through. We'll give you an overview of what's going to be in health pathways for you, have some more poll questions and an opportunity for Q&A. And I'll be monitoring the chat throughout, and if it's relevant, we might ask a question or we'll be saving them towards the end. Next slide, please. So I am Sue Hookey. I'm a GP. I work at Royal Melbourne as GP liaison. So if you need to contact Royal Melbourne, I'm often there as a person that can help you. So look up under health professionals, GP liaison on the Royal Melbourne website, and hopefully when I'm there on a Monday or Thursday, I'll be able to help you with some queries. We have with us today also from Royal Melbourne, Dr. Asha Bonney, who's a respiratory and sleep physician, and she has many other amazing roles and is a leading light in this area of the lung cancer area and working with the screening program. We also have Associate Professor Renee Manser, another respiratory and sleep physician at Royal Melbourne, and Peter Mack, and she's got a PhD in lung cancer screening and is an honorary associate at the Department of Medicine, University of Melbourne. So we have some great speakers, and Alistair Miller. Dr. Alistair Miller is a respiratory and sleep physician at the Royal Melbourne, and Peter Mack, and has a lot more that he does, but he's not sharing with us today. So welcoming our great speakers, and next slide. So we have a poll, so we hope that you're able to access the poll when it comes up. If you can answer that, please.
Great, thanks, Sue. So there's just 6 questions to go through, which you should be able to answer on your screen. The first one is about how frequently you manage pulmonary nodules in your clinical practice, how commonly you refer pulmonary nodules to a specialist clinic, how confident you feel assessing pulmonary nodule risk, and then how confident you are in terms of managing incidental pulmonary nodules, and do you use any guideline to manage pulmonary nodules, and how confident you feel in terms of managing lung cancer screen detected pulmonary nodules. So we'll just give you a few more minutes.
So do try to have a go if you've got access to the poll. We'd love to have your responses. We've only got about half of the people who've responded so far. So I think we're almost there.
All right, Olivia, should we end the poll now? Excellent.
Yeah,
Thank
we
you.
haven't moved from 15 for a while.
Good. I've still got the poll appearing. All right. So I might jump straight into the first talk, which is about pulmonary nodules. And really what I'm hoping to cover in this talk is more of an overview of pulmonary nodules and covering some of those fundamentals. So in brief, I'm talking about the definition, nodule characteristics, nodule presentations, some of the common causes for pulmonary nodules, and then also discussing some of the risk factors for pulmonary nodules. And then Alistair Miller will be talking, as we mentioned, more about the management and risk assessment of incidental pulmonary nodules. And Renee Manser will speak specifically about screen detected pulmonary nodules and further workup of suspicious nodules. So there's quite a clear definition about pulmonary nodules, and this is from the Fleischner Society. Essentially, a pulmonary nodule is a circumscribed, typically round opacity that is less than or equal to 30 millimeters in diameter. And it's different to a pulmonary mass, which is anything that's greater than 30 millimeters or 3 centimeters. And it's important that we don't use these terms interchangeably because the management is quite different if you've got a pulmonary nodule versus a pulmonary mass. The key characteristics that we like to know about from our radiology colleagues can really be grouped into the shape and the margin of a pulmonary nodule. So is it a rounded lesion? Is it more elongated or flat? And also about the borders. So is there irregular borders? So this is an example of what we would call a spiculated pulmonary nodule. Other characteristics can be lobular, and those are more suspicious features for things like lung cancer. The other key factor is about attenuation and structure. So what is the density of the nodule? Is it a solid pulmonary nodule like this one? Part solid, which means that there's an area that's solid, but also that there may be an area that's non-solid. And this is an example of a patient who has a part solid pulmonary nodule that's been followed up over time. And you can see here over time, there's this increasing size, but also increasing density where this nodule is becoming more and more solid in nature. Non-solid is one of the newer terms that we use rather than pure ground glass nodules, but essentially there is no solid component. So you can see there's that haziness, you can still see the underlying structure beneath the nodule there. There are also other types of lesions like cystic nodules or cystic pulmonary lesions like this one, which are increasingly being recognised as having the potential to be malignant. Other characteristics are if the nodule is calcified. So a lot of the time when a radiologist says there's a calcified pulmonary nodule, they're referring to reassuring features. A calcified pulmonary nodule is often benign and doesn't necessarily require any follow-up. But it's important to note that there are also some patterns of calcification, for instance, eccentric calcification, which can be associated with malignancy. And so paying, I guess, attention to what the radiologist is commenting on and their conclusions about the likelihood of it being cancer. Other features are if it contains fat, so something like a hamartoma, or air. So is this more of a cavitating lesion, which can be malignancy, may also suggest something like infection. What we also want to know is the location. So is it peribronchovascular, centrilobular, fissural or periphyseal, which are often more reassuring in nature, pleural or subpleural, peripheral versus central. And we're also increasingly recognising these endobronchial lesions as well, which may require different follow-up. And so hopefully with most of our CT reports, we are getting at least the density and attenuation of these nodules and some of these suspicious features being reported, because that's the information we need to know in terms of deciding further follow-up. So how do lung nodules present? Well, by the vast majority, most nodules that we see are incidental. So that is, they are asymptomatic. They've had a scan for another reason that is not looking for a pulmonary nodule, and they've been found to have this area of abnormality. And certainly the frequency of incidental pulmonary nodules is on the rise. You can see here in Australia, there is over 200% increase in the number of CT scans that have been performed over the last 20 years. This is from an American study with one of the insurers where they looked at as well the number of CT scans that their patients were having. And again, over a 6-year period, you can see quite an increase in the number of CT scans performed for any reason. And then they've commented on a positive CT scan. It's a scan that has a nodule detected. And you can see here fairly consistently, almost a third of patients who are having a CT scan for any reason in their cohort were having a positive scan for a pulmonary nodule. So very common. This is some work that we did looking at the prevalence of pulmonary nodules detected incidentally on non-cancer related imaging. And again, you can see here by the imaging type, there is quite a broad range of prevalence of incidental pulmonary nodules, not unexpectedly for patients having CT scans performed for cardiac purposes. So pre-TAVI or CT coronary angiogram, they have a much higher prevalence. So over 25% in some studies versus studies that are performed in, for instance, trauma series or abdominal CT scans, which have a much lower frequency. And one of the potential side-on or consequent effects of lung cancer screening is, as radiologists who may not routinely look at CT chests or look at the lung parenchyma are becoming more comfortable with using, and looking at CT scans and evaluating pulmonary nodules, and as they're using more computer-assisted diagnostics, that we may actually see a rise in the incidental detection rate of pulmonary nodules on non-screen detected scans or non-CT screening scans. Other presentations, so you can get patients who are symptomatic, but to be honest, most patients don't actually have symptoms. So often we see patients who have had a cough or maybe had an episode of hemoptysis or maybe chest pain on the left who have a CT scan and they find a nodule on the right. So often we get nodules that are detected that are not the cause of the symptoms, but certainly nodules can cause cough, hemoptysis, chest pain, dyspnea, wheeze, fatigue, weight loss, fevers, and also recurrent infections, particularly endobronchial nodules. We are, of course, going to start seeing screen-detected pulmonary nodules, and those of you who had patients of ours that were part of the International Lung Screen trial would have already seen some nodules in a trial setting from lung cancer screening. This is from the British Thoracic Society guidelines, where they looked at the prevalence of pulmonary nodules by incidental or screen-detected. You can see that the range is much higher in screen-detected or screening studies to have a pulmonary nodule detected. But overall, the actual prevalence of lung cancer remains quite low. The other way to detect nodules can be if they're having staging scans for other cancers. So that's another way that we will detect it. The British Thoracic Society did look and say, well, is there any difference in nodule characteristics between how the patient is actually detected to have a nodule or their route of presentation? And they actually found that there was no study that actually compared the different routes of presentation. What's more important is the nodule characteristics themselves and also what the patient characteristics are. And obviously in our cohort of screening, these patients are going to be quite high risk as that's their selection criteria. So in terms of what causes pulmonary nodules, well, a lot of the time for patients, we don't do invasive biopsies, so we don't get a 100% certainty of what's causing the pulmonary nodules. But these are the common causes. I've listed primary lung cancer up the top because that's obviously one of the biggest concerns, but it's certainly not the most common cause of pulmonary nodules. Certainly over 95% of incidental pulmonary nodules are not going to be cancer. Again, this is the prevalence of nodules and cancer by region. And you can see here, whilst they're very frequent, nodules are very frequent findings, the prevalence of lung cancer remains quite low. In addition to actually being primary lung cancer, we can see lesions, particularly those non-solid lesions, which can be precursor lesions. And it's important to distinguish that from invasive cancer, because often we will take a more conservative approach and monitor those lesions. Otherwise, we can see it in metastatic disease, infections such as tuberculosis, and so it's important to understand the patient's background risk of certain infections. Sarcoidosis is very common, necrobiotic, so for instance, in people who have rheumatoid arthritis, we do see people who have benign tumours, such as hematomas or lipomas. Arteriovenous malformations are quite rare, can be hard to distinguish, but some signatures may be if there's vessels leading into the lesion, even in a non-contrast scan, that may make you suspicious of it being an arteriovenous malformation, scarring, and of course, anatomical structures, so lymph nodes. So certainly granulomas and lymph nodes tend to be some of the more common causes for pulmonary nodules. So moving on to risk factors for lung cancer. So if we're looking at patients, what puts them at higher risk for lung cancer? First and foremost, the biggest risk factor for lung cancer is active tobacco smoking. You can see a relative risk increase of 10 to 40% with active tobacco smoking. Cannabis smoking, the evidence is not quite as strong, but certainly there is evidence to suggest an association with lung cancer. And increasingly, we're having more and more people start smoking e-cigarettes. And we don't have the longitudinal data. So for tobacco smoking, the lag time for lung cancer development can be around about 20 years. So we don't have that long-term data to say confidently that there is definitely an association. But certainly in early animal models, there does seem to be a suggestion of harm and increased risk of lung cancer. There are a number of environmental exposures. So asbestos being a common occupational exposure, a number of other substances, but increasingly as well, ambient air pollution. So for patients of ours that have grown up in areas that have high ambient air pollution, that can also put them at a higher risk of lung cancer. Genetic factors, particularly first-degree relatives, are associated with an increased risk of lung cancer. There are some diet factors such as increased red meat or low fruit and vegetable consumption. Low levels of physical activity has also been associated with increased risk of lung cancer. And then for us, thinking about non-malignant causes, non-malignant lung disease, certainly we do see that people who've had previous tuberculosis or a history of COPD and certain interstitial lung diseases are also associated with an increased risk of lung cancer. So that's a bit of a whirlwind about an overview of pulmonary nodules, but I'll hand over now to Alistair Miller.
Thanks, Asha. So look, in the next sort of 15 minutes or so, I just wanted to talk about which nodules are we talking about when we discuss incidental nodules? How do we think about risk for these particular nodules, and what recommendations exist for surveillance, and what we recommend in that space? As Ash has talked about, these are nodules that are found on imaging where nodules wasn't the primary question. So these are not screen-detected nodules. They're not found on scans when people have presented with symptoms, not associated with lymphadenopathy, and there are no clearly high-risk features, because the workup for nodules in those cases is different than the case that I'll discuss. When it comes to risk, Ash has talked about many of the factors that we think about, and unsurprisingly, larger nodules have a higher risk than smaller nodules, and we think about small nodules as really being anything less than 6 millimeters, and we've started using that cutoff because the risk of malignancy for those nodules is very low, probably less than 1%, and that's in all comers. We know that the risk of invasive malignancy changes according to the characteristics of the nodule. So a part solid nodule is more likely than a solid nodule, which is more likely than a non-solid nodule to represent invasive malignancy. But the difficulty is that the agreement regarding the type of nodule is not particularly high, and so review by a specialist thoracic radiologist is really important if decisions are being made on the basis of the characteristic of the nodule. The other characteristics, spiculation, upper lobe position, and multiplicities are also important. We know that in terms of primary lung malignancy, the risk is higher with lower numbers of nodules, as opposed to multiple, particularly more than 10 nodules, where the risk of something else, non-primary lung malignancy, whether that's infection or inflammation or metastatic disease, is much more likely in those high number of nodules. The other features that we look for are growth, and the key thing is change over time, and obviously if the nodule is stable over time, its risk of malignancy is much lower. And because there are differences in the way that scans are performed and measured, variations in how a nodule will appear according to the phase of respiration, how the person is lying on the bed, and so there's some allowance for change from one scan to the next, and 1.5 to 2 millimeters is considered a significant change. That's if you're measuring it in a cross-sectional scan. There is a move towards using volume, and some radiology providers will use volume in looking at the size of a nodule. And about a 25% change is considered significant if measuring volume. The final thing we look at is change in the characteristics. So the development of a solid component in non-solid nodules, development of spicules in a solid nodule. So the key thing about these nodules, these incidental nodules, is that they're generally speaking, or very often, in people at low risk for lung cancer. And so it's really important when we're talking to the patients and thinking about how we manage that, is that we need to balance the risk of allowing growth or spread of what could be an invasive cancer, and balance that against excess scans. We know that the time around scans and waiting for those scans and waiting for results has quite a significant impact in the moment in terms of people's mental health. It's generally not considered to be ongoing, but certainly around the time of those scans. And we know that there are lots of scans ordered. We know that, as Asha said, there's been really large increases over time in the number of CT scans that have been performed. In 2020, there are about 5 million CT scans performed in Australia. And in the US, it's up in the nearly 100 million scans. And so making sure that we're using that resource appropriately is also an important part of it. In this low risk group, there's also a discussion about the risk of scans. You may have seen this paper that's been published in the last couple of months out of the US, where they looked at the number of scans that were performed. And as I said, it was 93 million scans in 2023. And they looked at the projected lifetime cancer risk associated with those CTs. There are some questions about how they have calculated that. They've used data from nuclear bomb or atomic bomb survivors from Japan. But there is certainly some concern about risk, particularly in scanned children, in terms of the lifetime risk. And they approximated from those 93 million scans, there are about 100,000 cancers projected to result from those examinations. The highest risk is in children if they're scanned at younger than a year. But in terms of the absolute number of cancers, it's adults scanned between 50 and 59, really, because that's when the bulk of scans are performed. Of course, in those who are very high risk for cancer, then the benefits of a screening program have been shown to far outweigh these small risks. In terms of recommendations for following up nodules, there are a great number of them, and they all have particular conditions around the recommendations and target populations. So Fleischner is the one that I'll spend most time talking about, and that is for non-screen detected nodules. The British Thoracic Society guidelines came out in, I guess it's 10 years ago now, and they, as Asher noted, were for any nodule, regardless of how it was found. The American College of Chest Physicians published guidelines in 2013 for incidentally detected nodules. And Renee will talk about lung RADS in a small degree, which has been developed in the US for screen detected nodules. And so the Fleischner Society began in the late 60s with a group of radiologists, and they are a now international multidisciplinary group focusing on thoracic radiology. They've published a number of papers, but are most known, I guess, outside the radiology field, certainly for their lung nodule management guidelines. They were initially published in 2005, and at that time they were really the only guideline that was relevant to CT detected nodules. There were guidelines prior to that, but they were really about chest X-ray detected nodules, and as I'm sure you all know, nodules need to be much larger and much scarier to be seen on a chest X-ray as opposed to a CT. There was an update for subsolid nodules in 2013, and the most recent version was published in 2017, although they are working on an update as we speak. So these guidelines are relevant for people who are 35 years and older. So for that 25-year-old who has a nodule found on a trauma scan, we can't use these guidelines. They are incidentally detected nodules in an individual who is not immunocompromised, so someone who isn't at risk of atypical infection and has no history of cancer. So the conditions really look at both the individual risk of the person having the scan and the measurement of the nodule. And so it's an average measurement of the length and the width. As Asher mentioned, they're generally considered to be round, and so that's easy, but they're often not. They're often elongated or lobulated, and so that average measurement is important. With regards to individual risk, the presence of chronic lung disease, so whether that's COPD, we know that emphysema on a scan increases people's risk. Interstitial lung disease, chronic suppurative disease is also a risk. Any sort of smoking history makes you not low risk, and other inhalational exposures, which are, generally speaking, occupational. Any first-degree relative family history and older age obviously increases your risk. The other thing to know about measurement is that it doesn't include the spiculation, so it's just the solid component. And in subsolid nodules, we really would like the measurement of both the solid component and the non-solid component, because it's really the solid component that we're most interested in. So when the guidelines are divided up into solid and subsolid nodules, and then according to the number. So this is for single solid nodules. And as you can see, in someone who is low risk, any nodule less than 6 millimeters, the recommendation is for no follow-up. And then there are increasing times for surveillance, which is quite clearly laid out. And they've given a range in these guidelines which allows for variation in risk according to the particular person in front of you. For multiple nodules, it's generally the surveillance is determined by the highest risk nodule. And again, there's a range of recommendations to allow for patient preference and individual risks. When it comes to subsolid nodules, again, it's divided by the character, whether it's non-solid or ground glass or part solid. And again, for these, the recommendation is an initial review to see if they go away, and then a longer period of review, because we know that if indeed these do represent malignancy, they often have a much slower change. And so we need to follow them for a longer period to really understand that behaviour. I'll just touch very quickly on the British Thoracic Society guidelines. They use a much more complex algorithm for stratifying risk. Again, they recommend CT surveillance for small nodules, and they then recommend calculating the growth on subsequent scans. And they talk about a volume doubling time, with larger numbers or larger number of days being less likely to be high-grade malignancy. They use the Brock model, which came out of the PanCan study in North America. And their recommendations for management are then stratified according to the risk of malignancy calculated from that model. And I'll show you what that looks like. It does certainly require more information and really requires a thoracic radiologist who's engaged with that and is able to give you all the information that you need. So this risk prediction model is available online. This is from the British Thoracic Society site. As you can see, they ask for age, gender, whether there's a family history of lung cancer, whether emphysema is present, and then the characteristics of the nodule with regards size, whether it's solid or subsolid, the position of it, how many, and whether spiculations are present. So just by way of example, if we take a 65-year-old woman who has some emphysema, has a 15 millimeter upper lobe solid nodule with some spiculation, the risk of malignancy for that nodule is around 50%. If for the same woman, we have a small lower lobe subsolid ground glass nodule, the risk of malignancy is very low, less than 1%. And so while these are extreme examples, it gives us some way of delineating those nodules where it isn't clear that it's very clearly benign or very clearly malignant. It gives us a bit more nuance in that space. The final thing I say, I guess one thing I'm not sure that we're particularly good at is talking about incidental findings and the fact that When we do a scan, we're obviously looking for something, but there's a very, very good chance that we'll find something else. And this is something that we can't really avoid. It's not a reason not to do scans if there's a good reason to do it. But I think it's worth discussing with our patients so that they're aware that that may occur. The Fleishman Society guidelines provide very safe and straightforward recommendations that cover the majority of circumstances when we find these incidental nodules. And I think everyone can safely use those, provided you have enough information to make that risk stratification, and have adequate information on the radiology report to be sure that the nodules are the size that they say they are. The final thing is that comparison to previous scans is vitally important when we're looking at nodules. And so if you have a scan and believe that there's been a scan done previously, that if it hasn't been done at the same radiology provider, then if it's possible, have those images transferred and reviewed and compared directly, because it's only really in that direct comparison of images, not just reports, that you can really get a good sense of whether in fact there has been any change. All right, and I think Renee is now going to talk about screen-detected nodules.
Thanks, Al. I hope I'm coming up. I'll just try and share my screen. I hope that's coming through now.
Not yet, Renee.
Yeah.
Oh, yep, there we go. It's up now.
All right, thank you. Thanks, Asher and Al and Sue. Yeah, I'm going to talk about screen-detected nodule management, and largely in the context of the upcoming National Lung Cancer Screening Program, which, as you all know, is due to launch in July. So I wanted to start by just an overview quickly of the program as it's proposed, and I'm hoping that most of you are starting to understand how this will work, but the eligibility criteria are fairly strict for this program. People who are aged 50 to 70 with no signs or symptoms of lung cancer, who've only quit smoking within the past 10 years and who have a history of at least 30 pack years of smoking, of active tobacco smoking. And participants for screening will be recruited through primary care, predominantly either as an organised initiative or predominantly opportunistic, I suspect. And participants will also be able to self-refer them for a screening assessment. So if they are eligible, it's anticipated they'll have a sort of informed decision-making process, and if they want to go ahead with screening, then be referred for a CT scan, which will be performed at a radiology provider that's agreed to take part in the program. And when that's reported, the report will go back to the National Screening Register, and the participant will be notified of the results, and their requesting practitioner will also be notified of the results. The participants will be notified in sort of broad terms about the results, or they'll be directed as to what the next steps will be, rather than, I think, be given an actual copy of the results. And so if it's a very low risk scan, they'll be notified of this and be told that they can come back and have their 2-year screening test. But if the results show any other abnormalities that need follow-up sooner than the 2-year scan, they'll be asked to come back to see their referring practitioner to discuss the results. And some of those results are outlined in the top right-hand corner here, but I'll go over that in more detail as we go through. This is just a quick reminder of the importance of referring people with symptoms through an alternative pathway, which is this excellent guide that's been put out by Cancer Australia for the investigation of suspected lung cancer. And so if people have symptoms of whether it's, you know, weight loss, fatigue, or cough or hemoptysis, it's far more important to follow this algorithm rather than to refer for a screening scan. And obviously there's several reasons for that, but primarily because you want them to be worked up quickly and be referred for lung cancer assessment down a different pathway. But secondly, if they do have symptoms, we need to remember that the radiologist will be interpreting the CT scans based on the, you know, in the screening program, based on the assumption that they're asymptomatic. And sometimes it may affect the way you interpret a finding to know that there are symptoms. And the other reason to avoid performing a scan when someone has acute symptoms is that particularly if they have symptoms suggestive of a recent cold or a flu, that they may show some inflammatory changes which will be areas of consolidation, for example, which will mask the underlying lung, and the scan will be reported as an incomplete scan, and there'll be a recommendation for a follow-up scan. So if there are symptoms that are really suggestive of lung cancer, they should go down a workup algorithm. If they've got, in those people who are potentially being recruited to screening opportunistically, so they might be seeing you with a cold or a flu, you don't suspect lung cancer, then I'd also recommend that you don't do the screening test at that point, because you're likely to find some inflammatory changes, and most of the screening study protocols would have redirected participants to come back and have a scan done at 8 to 12 weeks after those acute symptoms have resolved. So I just wanted to talk about the program nodule management protocol, which has only recently been released, but it's an excellent protocol that's been put together by a lot of hard work from people working with the Department of Health and Cancer Australia and the Royal Australian and New Zealand College of Radiology and various other bodies. And they've based the protocol on three sort of resources. As Al's already pointed out, they use the PanCan nodule risk calculator, which is a very validated risk calculator in the screening population. And for this calculator, one of the inputs is family history, and I think Al's mentioned that. But this is going to be recorded when the CT scan is requested by the primary care provider. So this refers to the first degree relatives, so people who've got either a sibling, a child, or a parent with a history of lung cancer. The other set of information that's been used to inform this nodule management program is from the International Lung Screening Trial, which was performed in both Australia and Canada. And as Al's mentioned, the LungRADS nodule management algorithm, which is used in the United States for their screening program, and it has been developed by the American College of Radiology. So just to look at what the nodule management protocol will look like, I've tried to keep it simple for this first slide. So there'll be three main categories that results will be reported in the form of. So the scan will either be normal or very low risk, and in that case the participant would stay in the screening program and have a 2-year follow-up CT. Scans may be reported as either low to moderate risk, that is a nodule that's thought to be a low or moderate risk of being a lung cancer, and those participants would be expected to stay in the screening program and have a repeat scan at 3, 6 or 12 months, depending on the risk level. And there's a much smaller group of participants may have a high to very high risk scan, and they will be referred to a respiratory physician linked to a lung cancer MDT. So of course, it's not that simple. I tried to simplify it for that, but this is actually what the nodule management protocol flowchart will look like. And at the sort of either ends of this, there's some additional categories, which are the incomplete scan that I mentioned before, where the radiologist cannot basically see the whole underlying lung because there may be an area of consolidation or airspace opacity, and they'll generally recommend a repeat scan at 1, 2 or 3 months. There will also be some additional findings that are unrelated to suspected lung cancer. We expect maybe about 20% of scans will have actionable additional findings, and those will need to be communicated also to participants and any follow-up according to guidelines. But we'll have another session to talk about that. So we wanted to focus on, I think as we go through the group that fit really into this low to moderate risk of lung cancer, where the management is meant to stay within the program. And so that essentially means that they'll be managed by their primary care doctor, who will, in consultation with the patient, arrange these follow-up scans and follow-up results. So just to go over what those risk categories look like in more detail, this is the standardised reporting format that the radiologists will be using. This is the descriptors used for the baseline scans. And so for the baseline scan they will be using the PanCan to calculate the risk of malignancy. This applies to nodules, but doesn't apply to airway nodules or to complex pulmonary cysts. So there are some other descriptors there for those type of lesions, but it will be primarily based on the PanCan risk. You can see there the category of very low risk nodules, that some of those features of reassuring nodules that have been touched on by Al and Asher are that if you have a nodule which is completely calcified or has central calcification or contains fat, these features are suggestive of a benign nodule, and they don't need any particular follow-up. And so nodules that are either very low risk or where there are no nodules, they will be asked to have a repeat scan in 2 years' time. If there are nodules which are low risk, so that's a PanCan risk of between 1.5 and 6%, the recommendation will be for a 12-month scan. Where the risk is that of 6 to 10%, there'll be a recommendation for a 6-month scan, and where it is for between 10 and 30%, the recommendation will be for a repeat scan at 3 months. And the high-risk nodules will be referred on for specialist workup. So this slide includes some data from the International Lung Screening Trial. This is limited data from the Melbourne and Brisbane sites which took part in this study, but it reassuringly shows that for that category 1 group of participants, the very low risk group, that the majority of people who have a screening test will fall into this category and won't need to have any follow-up scans until the 2-year interval. About 12% we can anticipate will have those usually quite small and low risk nodules that don't require a scan until about 12 months. And about 6% will fall into either low to moderate risk or a moderate risk. And about 3% will have a sort of category 5 to category 6 requiring on referral. However, only about half of those with those high risk nodules we'll expect will end up having a diagnosis, or less than half will end up having a diagnosis of lung cancer. I haven't put together the actual algorithm for, I haven't included a copy of the radiology algorithm for the follow-up scans, but it has a similar sort of look to the baseline scans. But because the PanCan is only developed for the baseline scans and can't be used to as a risk calculator on the follow-up scans, there is a separate stepped management protocol that's been put together for the follow-up scans. And this will be based on the nodule characteristics. Both Asher and Al have spoken to you in detail about the difference between solid, part solid and non-solid nodules. And it will also be based on whether there's been any nodule growth. But there'll be a similar range of categories 1 to 6. And so for stable nodules, they will move down the categories progressively. So for example, if you have a category 4 nodule, which is stable on the 3-month CT scan, this will become a category 3 nodule at the follow-up with a recommendation for a 6-month scan. And if it's stable at that 6 months, it will then move to a follow-up scan at 12 months and so on. And for category 2 nodules, which are stable at the 12-month scan, they will have a recommendation for a further 12-month scan, and then they'll move into the category 1 for a 24-month scan if they have been stable over a period of 2 years. When nodules demonstrate any growth at the interval scans, they will move up to the relevant category depending on what size of the nodule, what the size the nodule is on the repeat scan. So I'll just. So in terms of communicating the results, this is also a graphic that's been put together for the National Lung Cancer Screening Program. As you can see, just to remind you that the results will come in this form of very low risk through to high risk or incomplete scan. Participants who have a very low risk scan will be notified by the screening register, and they won't need to come back and have the results, but they will be notified that they should have a repeat CT in 24 months. That's unless there are any additional findings that need to be followed up. It's anticipated that for participants who need to see their primary care doctor for the results, however, will get either a text message or a letter from the National Cancer Screening Registry to make an appointment to see their doctor, and the requesting practitioner will also be notified about the results. And at the follow-up, the same thing will happen. So when a CT is due, the requesting practitioner will be notified of this, and they'll notify the participant, and the participant will need to make an appointment with their GP to arrange the follow-up CT. There are some resources that have been released for the National Lung Cancer Screening Program, and I think this one about lung nodules is very useful. I think if this can be provided to participants before they have their CT, I think it will help to alleviate some of the stress and anxiety and worry about having a positive result, given that we anticipate, about 20% of people may have a nodule. So they explain the nature of nodules, the fact that they're common, and that the vast majority are likely to be benign. This graphic also explains the risk of finding other non-lung cancer related findings, which I think is important because, as I said, about 20% will have some actionable findings that they'll be expected to come back and discuss with their referring practitioner. And the other thing that it reminds participants is that if they do develop any symptoms in the interim, that they should go back to see their primary care doctor to discuss that. I think that's important because there are, even with a negative test, there's a small chance of developing an interval cancer. So as far as I understand, having looked at the recent information released for the National Lung Cancer Screening Program, this is the information that we provided to participants about what their results mean. And so you can see here that for the low risk and low to moderate risk scans, there's an explanation that, the scan has found something that they think is a low chance of lung cancer, and that there's a recommendation for a 12-month scan. And in the low to moderate risk group, the sort of advice is that there's something that needs to be monitored more frequently. So I think this is phrased in a way that hopefully will encourage people to come back for their scans, but is not too alarming. But it's going to be, I think, the challenge for primary care doctors to convey some level of reassurance, but also convey an adequate level of concern that means that participants will come back for their follow-up scans, but particularly for these scans which require a scan at 3 and 6 months, where I think, delays in imaging beyond the 3-month interval may risk increase the risk of progression of changes in that interval. So I'll just move on. So I wanted now to just talk very briefly about how we work up people in our, I'm just checking on our time, we're probably running out of time, but when we see a patient with a lung nodule that's referred to us, mostly with incidental lung nodules at the moment, this is sort of our thinking processes. These sort of categories that I've outlined here of low to moderate and high risk are not based on any particular numeric data. This is just really how we think about things in clinic. But when we see a person initially, we look at symptoms and signs and we review their imaging, and then make an assessment based on our judgment and in discussion with people, about patients, about how to next proceed. But if initially we think it's of low risk, we will often just arrange a repeat scan. But if there's some uncertainty of the nodule risk, we will often refer to an MDT and have our radiologist's opinion, which is very valuable. But also at that stage, hopefully look for any prior scans and compare that before deciding about whether a nodule may be high or lower risk. And those that are judged initially to be sort of low to moderate risk, we often refer for a PET scan, but this is really as a diagnostic test rather than a staging test. When we think initially the risk of lung cancer is quite high, we will also arrange a PET scan, but in that context, it's a staging scan. And there may be sort of other investigations such as brain imaging. So PET scans are often used for the workup of nodules, but this is just a slide to remind us that in the screen detected population, the test performance is not quite as good, and the negative predictive value in this one large screening study was only about 70%. So the sensitivity is sometimes poor, particularly for the very small nodules, less than 10 millimetres, and the sort of non-solid nodules, and those that are found on subsequent screens rather than on the baseline scan. When we think about nodule biopsy, we either think about radial EBUS for the more peripheral lesions, for the more central lesions, a CT guided biopsy for potentially for more peripheral lesions, and in some circumstances you may consider direct to surgery. There are multiple factors that influence our choice in respect to this, however, particularly where the lesion's located, whether there's an airway close to it, and the participant preference is very important because some people have a preference for certainty and others are much more risk averse in terms of biopsy. We also take into account whether there's a risk of increased risk of pneumothorax if there's significant emphysema, for example, and also what the local expertise is, so that if your local expertise is more in navigational bronchoscopy rather than CT biopsy, then this may influence what sort of biopsy you recommend. Ideally, however, it would be ideal to have access to all 3 potential biopsies after a discussion with participants about the risks and benefits of each. And this is just a graphic I put together to explain those risks and benefits in a little bit more detail. So a CT guided biopsy has a pretty good sensitivity, over 90%, but has a very high chance of a pneumothorax, some of which require a chest tube, and a small risk of bleeding as well, but a less than 1 in 1,000 chance of mortality, which is usually from rare events such as air embolism. Radial EBUS, which we have access to at Royal Melbourne and other centres around Melbourne, has a lower sensitivity but a much lower risk of pneumothorax and a lower risk of bleeding and a low risk of mortality. A wedge resection is a more definitive procedure, but has, 100% of people require a chest tube and a short stay in hospital, and there is about a 0.5% risk of mortality even for benign disease. So these are the sorts of things that we discuss when we're working up a nodule with the patient in clinic. And just I'd like to emphasise the importance of considering biopsy before proceeding to lung cancer resection or wedge resection. Most of the screening studies from overseas actually show that on average about 22% of surgical procedures performed in the setting of lung cancer screening are for benign disease. But some studies suggest that with adequate CT-guided needle aspiration, you can reduce that risk to about 8%. And data from the UK studies suggest that we should be aiming for less than 10% benign biopsy rate and from surgery. So just in conclusion, because I know we're running out of time, the screening scans will be reported in a standardised format using the National Lung Cancer Screening Nodule Management Protocol. The majority of scans will be very low risk, which will be reassuring for participants. We can expect about 3% of scans to have high to very high risk nodules, which will require on-referral to a respiratory physician linked to an MDT. And approximately 18%, though, will require earlier review at 3, 6 or 12 months. And these are expected to stay in the program and be managed in conjunction, in consultation with their primary care provider. And the participant information that's available through the National Lung Cancer Screening Program will be very helpful, I think, when discussing results with participants. Thank you. Just stop sharing.
Thanks, Ray. So I think we're now going to go into breakout rooms where we're going to go through some case studies, and then we'll reconvene after the case studies as a group. Olivia, you're able to. Thank you.
All right, everybody, if you could please move to your breakout room, that would be great. Thank you. Still have a few of you that haven't joined your breakout rooms. Are you able to just click join room on the main screen? Hi, Farm, Coco, and Marin. Are you having some trouble getting into your breakout rooms? We just want to make sure that you get the best out of tonight's session. Thanks for joining us again, Diane. I've just assigned you a breakout room if you want to pop into that.
just for my group, as I was saying, we would expect in terms of when you would refer or what point would you carry up the follow-up. So low to moderate risk nodules, if you're following an algorithm, you're comfortable, is fine to organise serial CBT. I think if you're heading into the realm of actually thinking this is really quite suspicious and maybe I would want to do a PET scan, then that would be a time to refer to us, particularly because that puts that patient on our books, and particularly in terms of getting the rest of the diagnostic workup in progress, we can kind of help facilitate that simultaneously. So did you want me to share the healthcare pathway slides?
That would be wonderful. Thank you. If you can't, I'll give it a go.
No worries. Did we need to do the poll questions first, or
Olivia?
yeah, just remind me.
We'll do health pathways first before the polls.
Okay, I can. Do you want me to share?
No, I've got it. Have you?
Okay, great. So we're just going to have a look at health pathways. Hopefully many of you are already familiar with health pathways. So our local PHN supports health pathways, and I've been involved with it from the beginning at Northwest Melbourne. And it's great. They're great ways that you can actually get some practical pathways. So the GPs are involved as clinical editors, and we have other GPs involved. And as the GP liaison, I also am that conduit to helping the subject matter experts help with the writing up of the pathways. So we have pathways for many different things. There's about 1,000 pathways, and they're amazing, great ways to look at evidence-based advice. You can look at everything in one go. We want to get people to have good evidence-based care. It helps you look at what way to refer into the hospital, how you can do as much as you can in the community, and then what services are available. Next slide, thank you. So this is what the landing page looks like once you've logged in, and a reminder that you need to get a new login. So everybody needs a login. If you were using a generic one in the past, you'll need to get your own individual login now. But once you get in, it's the same. So here we would be looking at our landing page, and on the left-hand side, there's the list of different conditions. So you would look, if you're looking about the lung, you'd be looking at respiratory, then you go down to lung cancer, and you'd also say look at referrals. So that's just something to be aware of. And if you find anything that you're finding is not up to date or we need to refresh, please always be aware there's this blue send feedback button. So if you find something that's not quite right, you can help us update it and keep it up to date. Next slide, please. So also with this being a new pathway, if you've got any comments, so new pathways, you can give some feedback as well, or if you're involved in the development of the pathway, there's a feedback to give. So not only if it's not up to date. So hopefully, Olivia might have some news for us soon on when this is going to be live. It's a draft at the moment, but hopefully by the time the cancer screening program launches, this will all be ready for you to look at. So there is information on the pathway, and as with all the health pathways, you've got the background, red flags usually at the top, red flags, your background assessment, and then if you want to, you can click on those buttons and expand bits out. But a lot of it is memory joggers, and you can just expand things out where you need to know a bit more, but you can see so much in one glance. It's wonderful looking at health pathways. Next slide, please. So there are a number of pathways that you might want to look at. So listed there are some of the different sorts of ones. So there's lung cancer, COPD, assessing respiratory presentations, asthma, asthma and pregnancy, bronchiectasis, chronic cough, asthma, thunderstorm asthma, non-acute COPD, and then if you're needing to refer people into hospital, there are various things there about admissions, referrals, lung functions testing, and that will tell you where you live and what are the relevant places to get lung function testing. When you click on those, pulmonary rehab, referrals for oxygen, and sleep medicine specialists, and vaping and smoking cessation, and the reminder about the statewide referral criteria for specialist clinics, because there are minimum referral criteria for you to refer to outpatients, and it's helpful to be aware of those. So you might get a referral declined if you haven't put everything in that is in a statewide referral criteria. So if you do get a referral declined or rejected, just don't get too offended. It might just be that the hospital has to fill triage according to the statewide referral criteria, and if you missed out some relevant investigations, that might get declined and you're needing to refer it back. And there is this great way that you can get some CPD hours as well. So next slide. So you are learning when you're looking at health pathways. So if you want to, you can click on the CPD hours for health pathways use, and you can, whether you're an RACGP or ACRM, you can log some of the time that you've been spending on health pathways. So be aware that that's an option for you. You are learning all the time that you're on health pathways, and you're improving your patient care. So make the most of it and use it more frequently, and you can create that CPD report for self-reporting. Okay, next slide, thanks. So as this slide says, you can either use the QR code, or you can go to your local PHN or the Health Pathways. Just Google Health Pathways Melbourne and it'll bring you up with the Melbourne, or look at the melbourne.healthpathways.org.au. So there's quite a few ways to find Health Pathways Melbourne and register if you have not already got a login for it, but really great source of evidence-based local pathways. Next slide. And there is a bulletin that comes out and it helps you get updated on things. Also, the Northwest Melbourne PHN has its own newsletter, and that often gives you updates on what's happening in health pathways as well. So if there's new pathways, click and get the newsletter for both the PHN and health pathways. So you've really got gold in them. And next slide. So we have some poll questions. So who's going to launch that for us? Is Olivia? Thank you. So please take a moment and make sure you fill in the poll, please.
There's only 3 questions, so if you finish early and you have some questions, you might want to type that in the chat because we'll be coming to that shortly.
So just while we're waiting for that, a question for Renee. You mentioned an MDT. So can you, for those who don't know what an MDT is, say what the abbreviation is and who might be attending one?
Thanks, Sue. Multidisciplinary team meeting. Usually we have we have a lung cancer MDT each week at Royal Melbourne and Peter Mac, separate ones actually, and they're usually attended by a wide range of people, so radiologists, oncologists, radiation oncologists, respiratory physicians, sometimes allied health nursing staff, and thoracic surgeons. I hope I haven't left anyone off, but basically we usually look at the imaging. Often it's a CT and a PET, and any biopsy results, and discuss management. Sometimes we'll discuss management before we've got a biopsy to discuss what sort of biopsy is most appropriate, or whether going straight to surgery is appropriate. Yeah, it's a very multidisciplinary approach to management, and works very well. I think it's very common for most cancers now to have that multidisciplinary team approach to management.
So another question in the chat is there a special form for the lung cancer screening referral? So those would not have come out yet, is that right? They'll be coming out later, or what do people do if they want to do lung cancer screening? And how do we know
do you mean the
they can go?
request for the CT, or do you mean the
Yeah, the referral or request. So when is it actually all launching, and when would people have specific forms for it, or do they just, how do they do it?
So there is, so it's launching 1st of July is the plan, and the government is on track according to all of their advertising. In terms of the CT scan, there is going to be a generic referral form for CT scans, which I think we might have had a look at in the last presentation, which has basic details, including family history, which the radiologists do need to interpret their results. Whether or not certain providers also have their own separate referral forms, possibly, but they should be accepting the universal referral form, which will be available via the program. I'm not sure if the program's actually released that form yet. We can probably end the poll as well. Excellent. I think that's done.
Yeah, so the Northwest Melbourne PHN will be doing, I'm sure, a lot of publicity, letting people know about how to access the forms, where to access them, and the providers who are available.
I just wanted to also, before we get finish up with the questions, just highlight some of those resources that Renee shared, where you can access the government resourcing. So this is the government website for the National Lung Cancer Screening Program, and they specifically have resources for healthcare providers, including a GP resource guide. They also have online modules that you can complete, and specific documents about CT scan, how you request it, interpretation, communication of the results. I do believe the government is also planning their own educational series, and so our educational series is really designed to complement their educational series without having too much overlap. So we've tried to pick topics that we can go into a little bit more detail as respiratory physicians, and also go through a little bit more about what our local resourcing and structure is available to you in our area. But there's going to be some really great talks coming up that I'd encourage you to have a look and keep an eye out for. There's also a number of resources for patients. So as Renee mentioned, there's a great pamphlet on lung nodules. There's also about CT scans, the process of screening. There's a whole list that literally got updated, I think, last week or the week before. So I haven't had a chance to go through all of them, but have a look at the website and have a look what's available for your patient. And just for us, so we are at the Royal Melbourne going to be commencing a dedicated lung nodule and lung cancer screening referral pathway, and this is being funded by the Victorian Government and the RMH Foundation, and that's part of what this educational series is to try and help equip our primary care colleagues with some additional knowledge and resourcing about how to manage and navigate the lung cancer screening process and some of the flow and effects from that. As part of the program, we are going to be having additional supports with a clinical nurse consultant, including a telephone and remote linkage that you can contact us for advice, as well as additional clinics. We're still in the process of finalising all of those materials and advertising, but that should be available in the next month or so before screening commences. And we'll be advertising that through the Northwest Melbourne PHN, as well as the Royal Melbourne communication channels. Because it is funded through a research pathway, there is an opt-out consent that needs to be given to patients. They'll receive standard care, but it's just to go through these new pathways. So if patients don't want to go through the pathway, they still have the option of going through our usual referral pathways. And that was it. So if there's any more questions.
So we haven't had any more in the chat. Was there anybody else who wanted to put something in the chat? Do patients have access to patient results? So how GP is going to get access to the results? Well, because they're making the referral, they'll be getting the results back. Is that right, Asha?
Yeah, that's right. So, and I guess it's being administered through the National Cancer Screening Registry, like the cervical and breast and bowel cancer screening programs are at the current time.
And a reminder that the PHN will help you with case finding, because a lot of this will be getting systems in place in your practice to find cases, because there's specific criteria for people who are eligible, and some of the previous webinars have been about that.
And also, if you have access to the National Cancer Screening Register, you can also look up patients. So if you get a new patient who's been participating in screening, you should be able to find them on the register and find all of their screen results. Reports should be uploaded, as well as any tissue diagnoses or MDT discussions, I believe.
Any other questions? We would love to help you so you don't go away with the burning question. If you can put it in the chat or unmute, we would love to hear from you with our panel of experts. So seems like it's all a bit quiet. Remember, if you haven't renamed yourself, you won't be able to get the CPD points. So we had somebody called User and Moira. You need to rename yourself to get the points. And we'd like to have your feedback. So please scan the QR code and you'll also get an email. So please complete the survey in the chat as well. There's a link to SurveyMonkey, or there's scan the QR code, and you will be getting more access to lots of resources and more opportunities to come together on some of these webinars in the future. Thank you.
Great, thanks everyone. And as part of the feedback, there is the opportunity to suggest further topics that you may want as part of this educational series. As Renee mentioned,